everybody. Well, let me come down from this tree here. I was up there picking some fruits, and hopefully in today's video you can pick some fruits off your own tree.
We don't make mistakes. We have happy accidents. And you have a brand new, beautiful tree.
This is something that I was sitting in an ICU with a student, and this student might recall this if you are out there watching this video. And we were in an ICU, and we were really just talking about the simplicity of respiratory therapy, and I was breaking it down to the student. I could just see their eyes and everything just start putting it together and lighting up and making these connections. And then that's when I came up with this tree. And when I did, it's just one of these things. It's just a tool. It's nothing special or anything. It's just kind of categorizing, putting things in places, and maybe giving you a simpler or maybe a better understanding of some things, and keeping it simplified, guys. If we can do that, right, if you can keep things simplified, it always works out better for us, right? So let's see if this video can do that and you can get some fruits. All right, so let's do that. So let's move this ladder away from this tree that we were getting these amazing cuties off of. All right, so getting right into the video, guys. All right, so here, respiratory tree. So really what I want to talk about to help simplify things are, we tend as educators, as clinicians, all these things textbook, there's a lot of information coming at you as a student, as a clinician, as all these things that you're trying to learn, right? And especially in these very early stages, more in the student stage, right, for these respiratory tree, but this really help out clinicians too to make it simplified, right? Because in respiratory therapy, there are really only two things that we need to be concerned about, or that we work off of, right? And the first thing is breaking down this word here, and then we'll talk about those two things. Respiratory and therapy. The respiratory part of this whole thing is the gathering of our respiratory, whatever that is. And the therapy is the therapeutic or the treatment that we got off of our respiratory diagnosis, right? Now we're time to treat it. So let's keep that in mind. Respiratory therapy, two parts there. But then in respiratory, right? Let's start creating our tree. Let's come down here. Now we just want to simplify, right? We just want to stay in the respiratory area. Now, there are two things that we need to look out for as RTs, respiratory therapists. And those two things that we need to focus on and that we need to ensure for our patients, and this is where it falls on the RT's jobs, right? And here it is. It is, and I'm just going to give you the first two. It is breaking off into, we know, ventilation and oxygenation, guys. Oxygenation, okay? Ventilation and oxygenation, all right? So we already identified those are the two things that we need to look for, ventilation and oxygenation. So how do we split? We know this is the first split coming down. We need to get to one side or the other, ventilation or oxygenation. How would we do that? What's the best indicator to know if it's a ventilation problem or an oxygenation problem? And if you said ABG, you are correct. ABG, which is arterial blood gas. You get your arterial blood gas, and then you'll be able to see what side, or if it's a combo, but right here, for simple terms, one side or the other, right? So on that ABG, what is that value that you would be looking for? What is the thing that you're looking for ventilation? PaCO2. PaCO2. Oxygenation, PaO2. Those are the values off your ABG that you will be able to get to one side of the tree or not, ventilation or oxygenation, right? And if we go this far, and if you know me already and you've been through a couple of these videos, you know I'm going to ask you, what is our normal PCO2? We got to know our normals, right? 35 to 45, okay? All right, and what's our normal? 80 to 100. It's good to, this tree is to really put it together. I hope you are creating this tree. After we're done, you write this tree down. You do this. You break it down. And you're going to see it's going to help you put it on sections, right? Right now, we're just breaking it down. We're trying to get to one side or the other, ventilation or oxygenation. That's all we're doing, okay? And these are our normal values, okay? Normal. Okay? All right. So, keeping it going any further, okay, so we have gotten to this point in the row. We are now being able to split it to either be on ventilation or oxygenation. So once we know that, right, we're kind of already gearing to some therapies, right? If it's a ventilation issue, or we know the CO2 values are off, how do we now therapeutically manipulate CO2? And that is tidal volume and respiratory rate. Or as we know, prior videos and what you should know coming this video, frequency of breaths is the same as respiratory rate. Okay? So there's only two ways, guys. It's PCO2 or your CO2. There's only two ways to manipulate that, right? Or to adjust that. It's either your tidal volume or your respiratory rate. The same thing with PaO2 or PO2. There are only two ways to manipulate that. And what is that? FiO2 and PEEP. And PEEP. There's only two ways on both sides to navigate therapeutically how to adjust a CO2 or a PaO2, an oxygenation issue. All right? Now, are there any rules or anything that would go for this? That's the next thing on this tree. Well, I can tell you first off, this right here is what we call minute ventilation. Oh, that's just a recall from another video if you haven't watched that one. This is our minute ventilation calculation. So we manipulate ventilation by our minute ventilation, right? Isn't that tidal volume times respiratory rate? It's right there, guys. Okay. So, the rules I was talking about. Let's start with ventilation. Well, we know our normal values. Go back over here. Respiratory rate. I always want to put that over here. Our rate for R and R. What is our normal? See how we do this on this tree? Right? Breaths per minute. That's 12 to 20 breaths per minute. Tidal volume. What is it? Yep. 6 to 8 kilogram per ml. That's how we set our tidal volumes up. So respiratory rate normal, tidal volume normals. Okay, normal values 6 to 8 kilograms per ml on this, right? So staying with this one here, we already know 12 to 20 and this right here. So keeping it going. Is there anything to do? If we need to make adjustments, is there a pattern to do this? Yes, you want to make increment adjustments. We know tidal volume first, then respiratory rate. First tidal volume increments of 50 mLs. That's up or down, right? That's our increments. We make adjustments 50 mLs at a time, up or down, whatever way we need to adjust it. Too high, too low, you know which way to go. First tidal volume, then respiratory rate, right? And then how do you know rate? Well, you need to keep your minute ventilation in check. And what's our normal minute ventilation? Right? Normal ventilation, acceptable ranges are 5 to 10, but we want to keep that around 7 to 8, guys. Okay? 7 to 8 for minute ventilation. Okay? Normal, acceptable, 5 to 10, that's absolute normal. So that's how you get your rate. Once you do your tidal volume, you maxed out. We need to know that for ideal body weight, right? That's how we know if we're maxed out, 6 to 8. Okay, so let's go back over to the oxygenation side. Are they the same type of things? You see the process here, right? We're thinking about any process over here like we did over here, right? So let's talk about it. What do we do? What's the process? Well, FiO2 first, right? We know that up to, is there a rule? Up to 60% FiO2, and then PEEP, Okay? That is called refractory hypoxemia. So if they do not respond to 60%, they won't respond to anything greater. Okay? So then we need to introduce PEEP. Okay? And PEEP, we start PEEP up to +5. Okay? That's where the initial starts. And then we want to make our incremental changes 2 to 3 per change. Or up, right? Up or down 2 to 3 increments. Okay? All right, and then remember the ladder effect. Whenever you come back down, if you start with one, you got to come back down the other way. Reverse it. It's a ladder. Go up the ladder, come down the ladder, okay? And we'll go over that a little bit more. This is just a categorizing respiratory therapy. You can see what we're doing already. And you see how simplified we were making it? In all things respiratory, you need to get to one side or the other on the tree, because really it all boils down to one thing or the other, right? Ventilation or oxygenation as RTs. There's a lot of things that we do, but really what are we trying to correct, or what's our therapeutic? Respiratory therapy. What's our therapy, right? Well, don't get confused. Don't let it get to it. Always see if you can get to one side or the other on the tree. And then that's going to help you determine so much, right? Now you know the therapeutic. Like if we really drew a line right here, right? We can say all this top half was respiratory and down here is therapeutics. This is our therapies, okay? But here's where the real nuggets come from this, okay? Because now we have split this, and if you notice, there's 2 lines up here, okay? Well, those 2 lines are purposeful, because I'm now, if I saw it split this way, and we talked about respiratory on this half, and then therapeutics or therapy on the bottom half, then I'm going to split it this way. We've already done that, right? You can see that splitting down. Ventilation, oxygenation. Can we categorize things on those categories? Most definitely we can. And I'm going to tell you who has, if we're talking about categories, right? Ventilation issues. Obstructive disorders, guys. And if I'm going to say that, those are CO2, right? Those are ventilation issues, right? If I said that, would that give you a clue to oxygenation? Right. We should start categorizing restrictive disorders in the oxygenation categories. They're going to be your oxygenation patients. Obstructive going to be your ventilation. That's what we have to worry about. Now, we're going to break down the list, and we can say under obstructive, it's in the name. Let's start thinking about it. And you can elaborate as far as you want on this. After this video is done, you can go as far as you want on this category. I'm going to just keep it very simple for teaching methods, and you can see obstructive disorders, COPDs, right? Chronic obstructive pulmonary disease, right? Restrictive, what's the big one on this one? ARDS, acute respiratory distress syndrome, right? So those are, you can elaborate on that, right? On a PFT, what would you see over here? Well, we know FEV1, right? FVC, that's the best predictor for COPD. And if we are what? And that has to be 70% or above. That's good. If it's lower than that, then we know we have something wrong. But that's something we can put over here too, because we know we need to have that on this. And what is the best predictor on PFT, bedside spirometry, whatever we're talking about, both sides? This one is your vital capacity, 80%. That's the best predictor, 80%. Sorry guys, that's an 80%, okay? That's your best predictor for vital capacity when you're doing PFTs. But all I'm doing is really just telling you, vital capacity, if it's less than 80%, you got a restrictive disorder. If you come over here and you got FEV1, FVC, and it's less than 70%, you got an obstructive disorder. I'm just putting it in categories, right? So if you did PFTs, you, like I said, expand as much as you want, okay? You're going to have increased TLC, right? RV, those are all qualities of obstructives. And then you can do the same over here. Your volumes are going to be low on this side, right? It's reversed, okay? Your volumes are low, okay? All right, so really just breaking it down, we can even now talk about mechanical ventilation. That's just called disease processes and PFTs and bedside spirometries. But can't we say volume control over here? And we can say pressure control over here, right? Restrictive pressure control, obstructive volume control. And then also test taking skills is, listen to this, listen closely guys, because I know in the clinic we all use BiPAP, but I'm telling you on the MBRC exams they want to distinguish those two and what those two are. So here, obstructive, they are worried about ventilation, and then we know that if it's non-invasive ventilation, right, that we want to use, that's the best method. You don't want to intubate, right? But if you can, you want to use BiPAP. Okay? BiPAP, because you know it's IPAP, EPAP, and it does do some EPAP, but really the focus is the IPAP or the BiPAP. If you get that NIV, non-invasive BiPAP, you select it for a COPDer. For restrictive, you want to select CPAP, because we know continuous positive airway pressure is the same as PEEP, right? CPAP, you select CPAP for oxygenation issues. If it's ventilation issues, you want to select BiPAP, all right? So as you can see, I'm kind of covered up with so much information here, but really, when you break this down, all this information has just been categorized. Please watch this video repeatedly till you get this down of where this split is happening. How to get this. It's an ABG. How do you know, right? Get to the ventilation or the oxygenation issue. And then once you get to that, you've already got there. Now, you just need to know what to do after that. So I hope this video really chops it up for you, and you can put these in quadrants, and you know obstructive and obstructive and restrictive ARDS COPD, and we can just keep going blah, 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 on all the things that fall in those categories, right? Characteristics, right? You could talk about many things, but the main point of this is simplifying respiratory therapy for you. It's getting it down and knowing that it really is down to the root of two things: ventilation and oxygenation. Once again, thank you for watching, and we'll see you at the next video. Thank you.